Good morning, everyone, and welcome to one more lecture of general surgery. And in this lecture, we are going to talk about trauma. So, basically, the important thing to mention before starting lecture is uh, all these lectures are interconnected with each other. For example, uh, in this one, we are going to cover trauma, and once, of course, we will cover the trauma. Uh, the next lecture will be about um, basically burns and thermal injuries, and the last lecture will be about organ transplantation. So let's start. We have already done shock, and before shock, we had done fluid and electrolyte management. So, um, like just two or three topics of general surgery are left. So this one is one of them. A very important lecture, I would rather say, because trauma is very common, and more details of everything you are going to cover in emergency medicine, right? So I'm going to talk about trauma um, in relation to what we must cover in general surgery. So, like what's written over here is like management of trauma under ATLS protocol. What is ATLS? It is Advanced Trauma Life Support. So, what is trauma? As you can see over here, it's a Greek word. A wound currently defined as mechanical injury to tissue by an external physical force. Um, Now, basically, trauma is, you can say, like it's injury, physical injury, and of course, like the injury always occurred due to some force or due to some physical force. Now the force can be of any kind. It could be what you can say a thermal force, radiation force, a chemical force, or XYZ. So simply as a result of any kind of force, like whenever we have any physical injury, we call it as trauma. And broadly speaking, when trauma, we say trauma nowadays, traumas are very common. For example, road traffic accidents and fall from height, occupational injuries, trauma can be of any kind. So, um, a brief history about ATLS now. Basically, advanced trauma life support is a course, and there is something called as BLS, which is basic life support. A very important courses, which people do before joining some hospitals. Okay, like almost all the hospitals require ATLS, especially someone who wanted to work in emergency, and like it's a training program, and it's very important to manage the trauma cases. So I like this trauma lecture. I include much of the things from ATLS. Okay. First of all, to tell you the importance of trauma, nowadays, uh, trauma is the most common cause of death, especially from 1 year of age until 45 years of age. Uh, and overall, like if we will not talk about just the specific age group, trauma remains the third most common cause of death in the world. And it's very important to manage and basically don't waste time, because as we proceed in this lecture you would understand that there is some critical time or golden hours which we have to aware, and if we cannot do anything in that thing, or if we will not do any intervention in that during that time, you can say there is high mortality, or reversible shock can be changed into irreversible shock. So as we know, like nowadays there is number of type of traumas. As I told you, road traffic accidents, occupational injuries and all these things. So uh, especially, motor vehicle accident or road traffic accidents are basically, you can say it's a global uh, epidemic, you can say, or pandemic, you can say, like it's like present everywhere. um, and nowadays, for example, all the motor vehicles, they are developing their technology, they are making it as safe as possible, but still, like, with technology, the traffic is also fast. So uh, nowadays, in the hospitals, you are going to see a lot of patients of trauma, especially RTAs, like road traffic accidents. So uh, now, um, what you can see over here, an effective trauma system needs a network of EMS and emergency medicine services, trauma surgery, and subspecialist. Okay, so of course, like, whenever nowadays, whenever, like, they see any patient with whenever they receive a call, if I will talk what you can say during this time. So what they do, like, there is two phases: pre-hospital phase and the hospital phase. So pre-hospital phase is, like, of course, the rescuers, they go to that place, they go at the site or the scene, uh, they uh, give the initial, you can say, the first aid or the basic life support or ATLS, whatever. But the important thing is, like, of course, once they receive the patient, they inform the hospital that, there is a patient, we are bringing it to the hospital who had trauma. And then once the patient reaches the hospital, of course, the hospital phase will start. So before the arrival of the patient, when they receive the call, what they do, by the way, like, they start preparing for to receive the patient. They, like, arranging bloods, or the hospital activate the emergency mode. For example, they inform the blood banks, they inform the surgeon, they inform the emergency medicine specialist, and all these ones. So EMS, emergency medical services, there are, like, three purposes: get to the patient quickly, fix what we can fix, and quickly get the patient to the right hospital. So now, there is a lot of discussion, and everything goes together. Like, you study a lot of things in forensic, for example. You will study a lot of things in emergency medicine. You had maybe study a lot of things in internal medicine. So basically, as a dealing doctor, like, you must be dealing the trauma, but not the other roles you have to play. For example, uh, whatever it is, either it's a try of a suicide, or it's a homicide, it's a road traffic accident, it's like during wars, it's a some natural disaster, whatever is there. Like, of course, the doctors, they must give the medical care to all the patients, right? So you can see, like, once the patient is, like, reach the hospital, uh, this one is a very, very, very nice, you can say, graph you can see over here. Golden hour: 80% of trauma deaths occur in the first hour after injury, and rapid trauma care has greatest level of impact in the patients. Okay, so you can see over here, the first hour, there is injury. So the first thing they do is the initial assessment or primary survey, and then they do the life-saving intervention, which in the bracket maybe you cannot see, but it's resuscitation. Then they go to a head-to-toe evaluation, which is the secondary survey. Then they re-evaluate, then they stabilize, and then they transfer. So this is basically what goes on in the hospital almost all the time. Okay, if you will see over here, see, after any trauma, like immediately, and then hours and days and weeks. So you can see, uh, 80% of the deaths, they occur in the golden hour, right? 80% of the deaths, and 20% of the deaths, of course, like after that phase is passed. So that give us like, simply what is the importance of time. So basically, uh, time is important because anyone who is involved with trauma, of course, like, for example, if someone is bleeding, right? So if someone is bleeding, so you can stop the bleeding by giving pressure or by doing whatever XYZ intervention. But once, for example, if the patient have too much bleeding, so due to that, for example, if their reversible shock is changed into irreversible shock, so of course, like, the mortality is high. Or for example, like someone who have tension pneumothorax, I will explain what is that. Or someone who have like any hematoma, or uh, extradural hematoma, for example. And then, of course, like, providing the care within minutes to hours, you can save the patient. But of course, like, obstructed airway, um, you have to provide the care within minutes. Otherwise, the patient may become, like, anything can happen, like, the patient can die because the airway is not patent. And that's the reason, they say ABC, like A is for airway, B for breathing, and C is for circulation. And that's how we go in reality as well. So the thing is that, how they do this thing, of course, we are going to discuss that thing in this lecture. Okay, so simply, uh, things goes in this way that you must be sensible enough uh, to remember the causes which can kill the patient, or you have must remember the causes which can kill the patient in minutes, or you have to remember the causes which can kill the patient in, you can say, hours, or you must remember the causes, for example, which can kill the patient in, like, often, like, you can say 2 hours, 3 hours, like this. So of course, like, airway obstruction can kill the patient right away. Whereas extradural hematoma, for example, the patient may survive for quite a bit, and then, of course, like, if you will not provide any care, then the patient will be dead. So that's the important thing, right? Uh, that we have to respond in the same way. We have to deal what is important, what can kill the patient, rather than dealing something which will not kill the patient instantly, right? Like, for example, if someone have a broken bone with a blocked airway, so of course, like, the attention should be diverted to uh, maintaining the airway first, and then saving the limb. Or for example, if someone who have a tension pneumothorax, and at the same time he have a broken like a fractured leg, so of course, like, the first attention should be on tension pneumothorax. So that's why it is important to remember this thing, that we must know the causes which can kill the patient within seconds to minutes, and then we go like from within minutes to hours. And then the third thing is like, we see the things like which takes hours to kill the patient. So now, this is the concept of golden hour, and this is how they respond, right? In reality. So now, after that, one thing is triage. Triage, like, what is that one? Okay, in the hospitals, by the way, they have triage system. For example, emergencies. If you have been to any emergency in any hospital, or in any emergency room, what you will found is that, there is multiple type of patients are there. There are patients with diarrhea, there are patients with vomiting, there are patients with uh, airway problems, there are patients of trauma, there are patients of infections, there are patients, like, so simply, there is a number of patients, right? uh, like with different problems. So we must know which patient needs the care at the earliest time. Of course, for example, uh, it's not about that a patient who have a diarrhea came first than the patient who have, for example, trauma, right? So of course, you can ask the patient who have diarrhea to wait for some time, but you cannot ask the patient of trauma to wait um, like for so long. Uh, there are okay. One of the thing. Okay, this is like a general example of like, but the photograph which you are seeing in front of you shows you simply multiple people who have trauma. So here you can see like there is like one, two, three, four, five, and six patients, right? So or seven, sorry, seven patients are there, right? So now the important thing to remember over here is what like um, these seven patients are there. For example, these seven patients were like people were going in a car who have seven seats, and what happened? For example, the car flip over or roll over, and all of these seven people they get injured. Now, the important thing to understand here is what like maybe the patients who are sitting in front, the driver and the front passenger, get most of the injuries, but the patient who was sitting in the back of the car, for example, or in the middle of the car, for example, maybe they have less injuries, right? So of course we must know that which patient we have to deal at quickly or instantly, and which patients we can give them attention like after dealing with the things which are more important, which can basically kill the patient. So of course, like, so for this reason we need some categorization and what you can say or in the what you can say in the cases of like natural disasters like earthquakes or any kind of natural disaster. Of course, many people they get injured, but not every patient have the same type of injury. And when they come to the hospital, being a doctor, you are the one who will, or the emergency department do triage. Like they basically categorize the patient. Either this patient needs any urgent care, or either this patient can be delayed for a while. So for that, these color codes are used in the emergencies. Uh, so, um, if you want to get a better idea about this thing, you must go through something called as Manchester triage. Though there is not a big difference, right? But of course, um, like it is like almost same. So you can see like the red is given to most critical injuries, the yellow one to less critical injury, and green one to no life threatened injury, and black one is like death or obviously fatal injury. Okay, this is very important. For example, if you can see if for example at the site of the uh, accident, if you will see that there is like three patients, right? And one of the patient is have that much bleeding that or like the doctors know that even if they are going to pay attention on him, it is not going to save the patient. Rather than there is one more patient over there who don't have much bleeding, but if the care will be provided to him, the life can be saved. But if you will not provide the care urgently, of course, like the patient can go or can die. So of course, anyone who has already died or who have obvious fatal injury which cannot be reversed, which cannot be treated, of course, like we should not pay attention on that. Like not like paying it. Of course, if there's just one patient, you are going to take care of that. But I am talking about mass casualties. I am talking about natural disasters. I am talking about when there is too much patients, right? Then we go for triage. So, uh, of course, like red will be given to those who need urgent care. Urgent care, like airway blockage, for example. Okay, green one, yellow one to less critical, and green one to like when there is no threatening injury. By the way, when I was working in emergency, I still remember that we were sitting in emergency and my seniors were there, and we were dealing with one patient, and there is a female. She came inside and she was shouting that, she need help, she need help, she need help. And my senior said that, she has so much energy that, she can shout. So it means like, we can see her after dealing with this trauma patient. So, but it's not always like this. But I'm just telling you, like this was his way. That this patient is so energetic. Of course, like she was standing, she was talking, and she was having just diarrhea, by the way. So, like this way. So it doesn't mean like the patient who is shouting a lot needs the care at the earliest. Okay. So this is a trauma team. You can see like it's a group, it's a multidisciplinary team, you can say. There is an anesthetist, there is anesthetist assistant, there is ortho registrar, there is nurses, there is emergency department physician, there is general surgeon, there are ward persons, there is a team leader, there is a radiographer. Okay. So of course, like the trauma team is not one or two persons, it's a group. It's a combination of specialities or skills which all put together and work together and deal with the emergency patients. So, okay. Now, this is the trauma team activation criteria, guys. You don't have to remember this thing. Just to give you an idea, see, for example, someone who have injury to two or more body regions, fracture of two or more long bones, spinal cord injury, amputation of limb, penetrating injury to head, neck, torso, or proximal limb, burns more than 50% in adults or more than 10% in children, airway burns and airway obstruction, right? So this is like the trauma team activation criteria. Of course, like all this one can are like serious injuries. And see, again, physiological criteria is like when the systolic blood pressure is less than 90, pulse rate is more than 130, which means the patient is in shock, or respiratory rate is less than 10 or more than 30, when there is altered level of consciousness, age greater than 70 with chest injury, pregnancy more than 24 weeks with torso injury. And then the last one is the mechanism. Like you can see the biker or pedestrian hit by a vehicle uh, at the speed of more than 30 km per hour. Anyone who ever fall from a height greater than 5 meters, anyone who is involved in some road traffic accident or a car accident and there is a casualty in the same car, and anyone who get ejected when there is a crash, right? So these are of course the criteria, and again no need to remember, but like just to give you an idea when uh, uh, the trauma team should be activated, right? So, of course, like the first thing what we do is like the assessment of trauma, right? So now, what happens in hospitals on in reality is like any patient, for example, who have a trauma when they are brought to the hospitals or to the emergency department, basically uh, the trauma team either they get activated or either they get activated before the arrival of the patient, and then of course we have to um, see the patient. So when we see the patient, the first thing, as I told you, is transfer and basic life support, and then we can go for primary survey, then we go for secondary survey. Okay. So what is primary survey? You can see A, B, C, D, E. Very easy to remember, and you have to remember in the same way. A for airway, with cervical spine. I will tell you what is that. B for breathing. C for circulation, with hemorrhage control, and D for disability. E for exposure. Okay. So A, B, C, D, E. So simply Uh, Basically, this system was developed in 1970s, like ATLS, okay, by American College of Surgeons. So simply, any patient who will come to the hospital or can come in direct in contact with the trauma team, what they will do, they are going to do approach him by this protocol. So uh, as you can see, that A is for airway, which means you have to assess the airway. C and with cervical spine protection. So what is this that remember this thing that whenever there is any accident or injury or road traffic accident, whatever is the way of the trauma, uh, you know, uh, whenever the cervical spine, whenever there is fracture in the cervical vertebrae, of course, if you will not take care of that, maybe you are going to damage the spinal cord. And once the spinal cord is damaged, of course, there could be paralysis of all the limbs, for example, or the lower limb, for example. So that's why whenever we check the airway, we take this thing in consideration that either the cervical spine is stabilized or not. Because if the cervical spine is not stabilized yet, so you are going to stabilize the cervical spine by giving a neck collar. That's a very important thing. And then we move on further. So A for airway, B for breathing, C for circulation, D for disability, and E for exposure. So the first thing, then comes of course the secondary survey, and in secondary survey, you can go through this way that you can take an ample history. By the way, how I remember this thing as sample. So if you will want to put over S over here, like, and make it sample. So make S as simply um, signs oblique symptoms, right? So that's an important thing. So you can ask for the sign and symptoms, like what the patient is having right now, and then of course, like, you are going to what you can say, go and ask about allergies, M for medications, P for past medical surgical history, L is for last meal, and E is for events, right, surrounding the injury. So in secondary survey, by the way, we take this history, and then basically we go from head to toe. We examine the patient from head to toe. Because basically in primary survey we deal with all the things which can kill the patient, uh, or by which the patient can die. Okay, so we address those issues, and we address for airway, breathing, and circulation. But in this one, of course, we take this history, and then we go for head to toe examination to do a detailed examination, like what kind of injury is there, what are the organs or things which are damaged, and what other care the patient is needing, right? So this is how they do. So okay, here it is written tertiary survey. So tertiary survey is a repeat clinical examination along the lines of the primary and secondary survey. It is performed with the aim of identifying injuries that have been missed during initial assessment, and this survey consists of a structured and comprehensive re-examination that takes place within 48 to 72 hours. So tertiary survey is not so important to remember, but primary and secondary surveys are very, very, very important to remember. Okay, never forget, and uh, very easy to remember. Remember A, B, C, D, E. Remember sample or ample, whatever you like. And if you remember all these things, of course, like, A is for airway, B is for breathing, C is for circulation, D is for disability, E is for exposure. And in sample, S is for sign and symptoms, A is for allergies, okay, M is for medications, L is for last meal, and the last A is last E is like event, like the surroundings. Okay, so let's start with primary survey now. A, B, C, D, E, right? We all know what is this. So the first thing we do is like airway. So maintaining a patent airway is always the first priority, and of course this is the most important thing uh, to consider. And of course, like, if the airway is not patent, the person cannot exchange the airs, so which means like there there is no oxygen going on inside the body. So the thing is, over here it's written over here GCS score of 8 or less. So Glasgow Coma Scale, if you know what is that, if the score is less than 8 or less, you can YouTube it. There is a lot of videos of GCS, how to perform it. I will talk in this lecture, but it's better to see the videos. Okay. The first thing, remember that whenever anyone GCS is less than 8 or 8, we go for intubation directly, right? So that's the important thing. So the last thing is again protection of the spine. That is, I told you, that is the key. That is the most important thing, right? Because in blunt traumas, cervical spine immobilization is very, very, very important. So basically what they do is like they apply the collar, and if you want to know what I'm talking about, like this, right? They apply the collar. Okay. And now the one of the questions which will come to into your mind, that this collar is not available everywhere. Of course, the paramedics, they do have, the rescuers, they do have, but in many times we don't have this thing. Of course, in that case, what we do, we use like sandbags. Okay, we put the sandbags on the side of the neck of the patient, on the to both sides of the head. So that's the important thing. Okay, so one of the thing which is quite understood, for example, if I will go to the patient and I will say that uh, can you hear me, then of course, like if the patient is responding and talking to me, of course his airway is patent. Of course, remember that if your airway is not patent, you cannot talk, the patient cannot talk. So uh, remember one thing, that it's always like this in the hospital, that we say it DRCABC. Okay, so what is D? D is for danger. Okay, whenever you are approaching any patient, always look for danger. Whenever you are approaching any site of scene of accident or scene of trauma, always look that your life should be safe. For example, if a patient, he was riding a bike in front of you, and while going on the bike, he got hit by a car and he fell on the road. Now, you being a very good doctor, you went to him and you started saving him, right? So uh, the important thing to, like, why I'm giving you this example, that you are trying to save him, you are trying to save that patient who just now fell from the bike. But for example, you started running on the road, and what happened, that as soon as you reach the patient, there is one more car that came and it hit you. So of course, like, uh, always look for the danger. So DR, always check the response of the patient. Check like, hey, can you hear me? Can you wiggle your toes? Can you wiggle your fingers and things like this? Okay. And C is call for help. So D for danger, R for response, and C is for call for help. Of course, like a few years back, or you can say like 15 to 20 years back, not everyone was having a cell phone. Telecommunication was not that much strong. Okay. Uh, but nowadays it's very easy. Everyone have phone. Everyone have access to what you can say, the helpline. Like different countries have different. In China, you can say it's 112, 911, or 100, or 111, or 15, whatever your country have that. So you can call for help. Call for the help. If you are in the hospital, of course, you can call for help. You can call your team. Things like this. Okay. So always call for help. Okay. So going further, you can see like the cervical spine and the neck. So you can see like they have applied the collar. Okay. So anyone in which you are suspecting a cervical injury, apply the collar. If you are sure you have cleared the spine, like there is no spinal injury, so of course in that case there is no need. Okay. Then we have to maintain the airway. Now, uh, as I told you, like if the patient is conscious, there is no need to pay attention on the airway. Okay. But if the patient, for example, he is conscious but he have trauma on the neck and the face, so maybe later on due to expanding hematoma, their airway can get compromised. So in burn patients, if you see uh, someone have burning of the nasal hairs, of course, uh, in that one, of course, a definitive airway should be maintained. Okay, so that's the important thing. Okay, so any patient, for example, who have abnormal voice, who have abnormal sounds coming out from his throat, for example, or the chest, who have tachypnea, who have altered mental status, we must evaluate their uh, airways. So you can see over here, uh, to maintain the airway, there are two ways. Like, of course, when you open the mouth, if you see any blood, any vomit, any foreign object, of course, you can remove that, right? Because those things can cause airway obstruction. So suctioning can be done. And now, if you'll see over here, if the patient is in this position, uh, the tongue can fall backwards and can block the airway. You can see over here, this one. Okay, this thing. Wait. Okay, basically this thing, right? So see this one. When you make the face like this, it is like the airway is patent. The air can go and come back. So remember two ways. One is chin lift and one is jaw thrust. Okay. You can say this is the chin lift. Okay. When you will do this thing, but of course you cannot do this thing in a patient who have a cervical spine injury. So in that one we are going to do jaw thrust. So that is the important thing to do, right? And see, then we can put them with nasopharyngeal airway or a definitive airway. We can give them oxygen. You can see we can give them bag valve mask, or we can do endotracheal intubation. What is endotracheal intubation? Passing a tube from the mouth and going into the trachea. So that is endotracheal tube. So simply that tube is basically taking the air and going inside the lungs, right? Directly into the trachea. Okay. If the airway cannot be maintained by that way, or if there's too much injury on the face, you can go for a procedure called as a cricothyroidotomy. In this one, they cut open the cricoid membrane, okay, cricothyroid membrane, so to open an airway so that the air can go inside and outside. So now what you will see is uh, this is the chin lift method to maintain the airway. But if someone have cervical injury, then you can go for a jaw thrust. So in jaw thrust, what they do, they bring the jaw forward. So when they bring the jaw forward, by the way, it opens the airway. Okay. So this is what I wanted to show you. Then you can see, if needed, we can put them with oropharyngeal airway. You can see like this one providing, or we may have one more thing called as nasopharyngeal airway, in which, like, so oro means from mouth to pharynx. Nasopharyngeal means what? From nose to pharynx. So nasopharyngeal airway. Of course, like that thing. And if we need a definitive airway, then we can go for endotracheal intubation. Okay. So endotracheal, as I told you, that it goes, nasopharyngeal goes up till here, but endotracheal goes down into the trachea directly. This is the bag valve mask airway. Okay. This is again the EC position to hold the bag and valve. Okay. And to provide them with ventilation. Again, see, this is the C and this is the E, CE. So that's why you hold it like in this way. This one is like when we have like a helper is present, and see how he's holding the mask and how he's maintaining the airway. Okay. So he's performing the jaw lift with uh, holding the mask, or we can go for endotracheal intubation. See, so basically we need a laryngoscope. This one is a laryngoscope, and then they are passing the tube. So What is endotracheal intubation? So guys, simply it's like passing that tube by the help of a laryngoscope by directly visualizing the vocal cords, right? By directly visualizing the vocal cords. Okay, so now this thing, and these are the, what you can say, places when there is advanced airway management is needed, like anyone who apnea, cardiac arrest, inability to maintain his oxygen levels, on face masks, severe head injury, maxillofacial trauma, penetrating neck injury with expanding hematoma, major chest injury like flail chest. I will explain this thing, and persistent obstruction. So, of course, like in these cases, we need advanced airway management, like endotracheal intubation. And as I told you, like if you cannot maintain any one of these things are not working, then we can go for one more thing. Okay, I will show you that, but after explaining this endotracheal intubation. Okay, so you can see, uh, I will not go in much detail of this thing, but what you can see here is what? Uh, Initial tracheal intubation, pre-oxygenate with oxygen, provide cricoid pressure, use a laryngoscopy, and if there is poor view, then reposition the head, reduce a cricoid, or use like ETT intruder, and if there's success, we should do two attempts, right? But if there's no success, then call for help. Then you can say you can use the type of airways. Okay, so now the important thing here to mention is that you can see we found difficulty in intubation. So there is a something called as Lemon assessment. So L is for look externally, E for evaluate, M for MLAPT classification can be used, O for obstruction, or N for neck mobility. So basically this is the MLAPT classification. Okay. Again, I think like if you have done anesthesia, you must know what is this, right? If you haven't done anesthesia, then wait. In anesthesia, basically they are going to talk in detail about this one and MLAPT scoring. So I will just tell you, like MLAPT scoring classification is just to tell, like, if someone have a difficult intubation. For example, you can see over here in this one patient, you can see the all the uvula and the tonsils are also visible. But if you will see in this patient, for example, a very fat patient, you can see like even the palate is hardly visible. So of course, like endotracheal intubation is easy in this one, but hard in this one. Okay, so that's why we use MLAPT classification. MLAPT classification, right? Okay, so in C-spine injury, of course, in that cases, what would they do? They do manual inline stabilization. You can see like he's holding the neck. So uh, what this person is doing, by the way, he is keeping his spine straight in the midline, so that when they put this endotracheal tube, the cervical spine will not be damaged. And the last thing is, which I want to show you, is this one. When there is no way, or when there is what you can say a very extensive facial or neck injury, then we can go for cricothyroidotomy. So you can see this is the Adam's apple. Below that, between the cricoid cartilage, there is a membrane. We can cut it and we can open it. You can see over here. So they make a cut over here. Okay, so you can see like this is the steps. They make a small cut and then they pass a mini tracheostomy tube. They pass a mini tracheostomy tube. But the main point is, of course, to maintain the airway. Okay, guys, by the way, the trauma can be of like, of course, I am discussing generally, but uh, there are many type of traumas, acceleration injuries, deceleration injuries, penetrating traumas are there. Okay, incisional injuries can be there, any kind of firearm injuries can be there, or penetrating injuries can be there. Okay, so this thing is important. So okay, Uh, okay. Now, one of the thing is what you can say. Okay, I think I can go further instead of talking about that. Okay, so after that we go for breathing and ventilation. So once the airway is secure, guys, okay, you know, and adequate oxygenation and ventilation must be assured. Okay, we must take care of like either the now the airways patent, so either the patient is breathing, either he is maintaining his oxygen saturation or not. So basically all the injured patients are given supplemental oxygen. Okay, and nowadays we have pulse oximetry in the hospital, so they're attached with that. So now in primary survey, we check the chest movements. Okay, so you can see over here we check number of things: uh, respiratory rate, um, pressure of like the oxygen saturation, you can say. We check the position of the trachea. We check either the chest expanding or not, and if it is expanding, it is bilaterally equal or not. We do percussion, we do auscultation. So you can see over here, um, again, like you have done the respiratory examination, you know what is inspection, palpation, percussion, and auscultation uh, in respiratory system. So we will go, like of course in emergency we don't go and do all these things. Rather, we just see the movement of the chest, either they are bilaterally moving and they are symmetrical or not. Okay, why? Because there could be number of problems. For example, one of the problem is tension pneumothorax, right? So tension pneumothorax is basically respiratory distress and hypotension. Okay, like uh, what happens, like if they have an injury and the air is going into the pleural cavity but not coming out, so the air will started collecting inside the chest and it will push the lungs and the heart on one side. Okay, so that's what we call it as uh, tension pneumothorax. So tension pneumothorax, the patient are in hypotension with respiratory distress, and there are signs of chest trauma with tracheal deviation. Of course, when the air will be here on this side, the trachea will be pushed on opposite side. Okay, and when we, for example, you auscultate, you don't found any breath sounds in that area, so it means like there is no lung tissue down below, right? So that's an important thing. We also check the neck veins. Okay, because the neck veins can become distended or they could be collapsed like because of hypovolemia. So like all these things, we see. So what is the quick treatment of this thing? We do needle thoracostomy. Okay, in the second intercostal space in the mid clavicular line. So see, they put a needle right away and the air escapes from the needle. Okay, so this thing, this is like how they treat tension pneumothorax. Then comes, for example, massive hemothorax. For example, someone have an injury and see, like this lung should be up till here, right? But now the blood is started collecting over here. So when the blood is started collecting over here, so it will become hemothorax, right? When there is air started collecting over here, it is pneumothorax. Okay, when fluid is started collecting over here, it is hemothorax. So this one is uh, hydrothorax, sorry, fluid. When uh, uh, lymphatic fluid started collecting over here, there it is collection of chyme or chylothorax, right? Simply whatever is collecting, you will put that thing. So hydrothorax, water is collecting. Hemothorax, blood is collecting. Pneumothorax, air is collecting. And when the air is causing pressure on the lungs so much that they cannot expand, and the patient presents with hypotension, it is tension pneumothorax. So now the important thing is again signs similar to tension pneumothorax. The patient will be in shock. So what they do? They do put a they do a thoracostomy. Okay, they put a chest tube. So that is called as thoracostomy. Okay, so of course, like we have to evacuate that area. We have to remove any fluid from that area. That's a very like important thing. So simply, if you can see any chest wound which is open one, or you found any sucking chest wound, uh, uh, or you found, for example, the chest wall is lost. Okay, so we must treat that, we must cover that, of course. That's the important thing. Then comes, so this is like open pneumothorax. Okay, so what is open pneumothorax? See, on inspiration, uh, it is preventing the air entry, but on expiration, okay, basically the trapped air is escaping. Okay, so this is like they, like whenever you found any patient who have an open chest wound, so we basically put them with this kind of gauze gauze cover. So if you will see over here, they put uh, what you can say, a gauze, and they tape it on three sides, basically four sides, but they leave a small place, so that when the patient do inspiration, the air cannot go inside, but when the patient do expiration, uh, the air can escape, right? So this thing can be done. Then comes the flail chest. So flail chest is, when someone's rib is fractured from 2 points. So when someone rib is fractured, like the same rib is fractured from 2 point, so it become a free floating segment. Okay, and it shows paradoxical movement. For example, when the patient is doing inspiration, the lungs are expanding. Okay, so this one will, like all the chest is going out. Okay, but this one will go in. But when the all the chest is going in, it will go out. So it is showing paradoxical chest wall movement. Okay, so of course, like if you found this thing, this thing should be dealt. And sometimes, like we send the patient for chest X-ray, for example, to identify. So this thing should be done, okay, or cleared. So then, for example, the patient can present with pericardial tamponade. Okay, so pericardial tamponade, what is that? So again, uh, when the fluid started collecting in uh, pericardium, okay, pericardial space. So in penetrating injuries, okay, this is called as Beck's triad. Beck's triad is like hypotension, muffled heart sound, and distended neck mass. When these three things are present, we call it as Beck triad. They are pointed towards that the patient have cardiac tamponade or pericardial tamponade, right? So of course, like there is a scan called as fast scanning. Okay, so it is like fast FAST. It is focused assessment. Okay, uh, and we, like, it can be done very quickly in the hospitals within 7 minutes. Okay, it's a, like, we check four areas like suprapubic region, splenic region, liver region, and pericardium. So if you found any fluid over there, it is called as pericardial tamponade. So we can also do echo, and the treatment is pericardiocentesis, like put a needle, take it to the pericardium, and take out the fluid. Okay, so this thing is important. Then comes the circulation, C, A, B, and C. So in circulation, of course, like once you have maintained the airway, you have checked the bleeding, then you will go for and check the circulation. So in circulation, of course, we can check the pulse, we can check the blood pressure, especially systolic blood pressure. We can check the color of the patient. Uh, we can do a capillary refilling time. You can check for the urinary output if there is time. Okay, but of course, in trauma patients, you don't have time to monitor the urine. So of course, like that is one of the way to see, like either like the circulation is enough or not. So what we do, by the way, in the hospitals, like they put like two cannulas, right? They put two cannulas, and they start the resuscitative fluid. And as we have already a lot of discussion about the resuscitation, what kind of fluids are available, what is like the blood products which are available, what is colloids, what is crystalloids. So based on that, we arrange that. But by the way, in the hospitals, once the patient is there, remember, if the patient is losing blood, the best substitute is blood. So there is O negative bloods which are available in the hospital, so we can give it to any patient. before doing cross match. Otherwise, we always cross match and we give the specific blood to the patient. So identify any hemorrhage, apply direct pressure to stop, okay, and be aware of the possible sources of internal bleeding which can collect in the chest, in the abdomen, in the long bones, especially around the thighs, okay. It can collect. So you can see, like for example, in pelvic fracture, the person may lose like up to 4 liter of blood, or in fracture of femur, uh, the patient can lose up to 2 liter of blood. So of course, like that's a dangerous quantity of blood which the patient is losing, and that is basically grade 4 hemorrhage. If you remember, we had already covered the hemorrhage, right? So in that case, we do this thing. So uh, again, this is the classification of hemorrhage. We have done this thing, and whenever anyone is losing 2 or more than 2 liter of the blood, we call it as class 4 uh, shock or class 4 hemorrhage, right? So this one is like uh, when we do for the circulation. So simply, guys, um, in circulation, the important things to remember is like to control the bleeding with direct fracture. If you found any limb which is fractured, you can splint it right away. Insert 2 large bore cannulas and uh, send off their blood for cross matching. Call the blood bank. Bring, if there is O negative, you can give the patient, okay, that blood. So now you can see fluid replacement should be done. We have covered these things, that's why I'm just passing them. Blood replacement, O negative, but yeah, I like the same points which I talk about, right? So this is the C circulation is going on. Okay. So these are the pitfalls in circulation. Elderly people, they have limited ability to increase heart rate. So remember, when the blood pressure is very low, the heart rate will be increased. Because if you know the formula of cardiac output, it is stroke volume multiplied by the heart rate, right? So whenever someone blood pressure is going down, so of course, like, or the blood is less, so of course the heart try to compensate by increasing the heart rate. So this thing is important. Then comes the D, that is disability, okay. And how we check disability, it's simply we check the GCS, okay. So what is GCS? GCS is Glasgow Coma Scale, and there is a simple mnemonic to describe level of consciousness, AVPU. If the patient is talking to you, he is alert, it is A. If he is not talking to you, his eyes are closed, but when you talk to him, he do respond vocally, V. If the patient is not responding you vocally, but when you apply some painful stimulus, they are responding, it is P. But if the patient is unresponsive, it is U. Okay, and then we check the pupils, right? Either they are bilaterally equal and reactive or not. So you can see over here, in this patient, there is one dilated pupil and one normal pupil. So it could be like the third nerve compression. In this one, there is bilateral dilated pupil. In midbrain injury, irregular pupils, you can see like this one. It could be in orbital trauma. If someone eyes are continuously looking on one side, it is frontal lobe lesion. So things like this. Now this is all neurology. Okay. Okay, guys, actually we don't have much time to talk about Glasgow Coma Scale. Okay. I will just talk a little about Glasgow Coma Scale. What I will suggest to you is to watch a good video of Glasgow Coma Scale on YouTube, because they will show you on the patient how we perform it, and it's very easy to remember. Remember EVM, E for eye, V for verbal, E for eye, V for verbal, M for motor, EVM. Eye opening have 4 points, verbal have 5 points, and motor response have 6 points. Okay, maximum. And the lowest each one have 1, 1, 1. So remember, the minimum score any patient can get is 3, and the maximum any patient can get is 15. Okay. So simply a patient who is spontaneously moving his eyes, 4. A patient who is, when you ask him to do, he can move, 3. If the patient is not moving when you ask, but on pain stimulus if he is moving, it is 2. So I will suggest you go on YouTube watch a full video on Glasgow Coma Scale. One thing I would like to mention over here is this is very, very, very important topic to cover. Very, very, very important. This is five-star thing which every medical student should know. Okay, that's why I'm stressing out. Watch YouTube, watch Glasgow Coma Scale, see the patients, try to understand what is this thing. So, of course, in this one, like when we check the disability, uh, we like the disability can be due to spinal cord injury, increase intracranial pressure. Okay, so these are the interventions which we can do. And after that, of course, E for expose. So remember, when you don't see, you don't know. So that's why exposure is very important. So what they do, like they cut open all the clothes, they do look all the body. You can see over here, for example, how many injuries they can see over here. Uh, in this one, if the cervical spine is cleared, there is no injury, you can move him like this. Otherwise, there is a log roll method. You can see over here. This is the log roll method. If you found any blood on the urethral meatus, never try to catheterize because you can make the injury bad. So these are the things. So after primary survey, of course, then we go further onto the secondary survey. And what a secondary survey, as I already told you, we take the ample or sample history very quickly, and then we go from head to toe examination. Simply, we check the head, we check the patient back, we check the axilla, we check the perineum, we check the abdomen, we check the chest, we check the thighs, we check the legs, we check all these things. Okay, we press the uh, uh, pelvic bone, all these things, right? And then we send the patient for things like x-ray and all these things. Okay, so okay, all these things, of course, like they go with primary survey. Like the patients, they need like CBP monitoring, ABGs, vital signs. So simply nowadays we hook them with the monitors. So this is how we do this thing. This is the Foley's catheter, guys, which uh, we put for urination, right? Uh, Contraindicated in urethral injury. As I told you, whenever you found blood on the urethral meatus, never put Foley's catheter. So this is how it looks like. This is a nasogastric tube, which is put uh, inside the patient tummy. Uh, so see, as I told you, like we can send the patient for chest X-ray, pelvic X-ray, lateral spine X-ray. DPLS diagnostic peritoneal lavage. Nowadays it is not done, rather FAST is used. Okay, FAST scan is easy. Like she's the one who is performing FAST scan. You can see very quickly we can perform. Okay. So do not do this thing in trauma. Never try to remove any impacted foreign object because it can lead to uncontrollable bleeding. Maybe that tamponade effect will be lost. Never try to put the intestinal loops back into abdomen in stab injuries. It can cause strangulation. Never insert anything nasally in head injury because it can like damage the skull base and damage the brain simply. Secondary survey, guys, ample history. You can see over here the same ample history which I talk about, right? And then we go for head to toe examination. So I hope you understand, okay? And I hope you will remember this thing. So thank you so much for listening. I will see you in the next lecture.